I want to thank Dr. Banerjee and the course directors for inviting me to this meeting and assigning me this challenging topic, which I think is not necessarily an expression of frustration, but more of reflecting on what we could have done differently in this time when we don't really know what would be better between endovascular versus open surgery. I think, when a case doesn't turn out exactly how we want it to turn out, we should pause and think about how we could have done it differently. So this is one of those examples. This is a 50-year-old man who came in with 3 weeks of right foot numbness and pain. Medical history significant for coronary disease, had a couple of coronary stents, hyperlipidemia, smoking, no diabetes. 1 month prior to coming in to see us, he started complaining of worsening right leg claudication and then came in with the symptoms above. On exam, he had palpable femoral pulses bilaterally, and on the left, which was the unaffected contralateral side, he had palpable pulses throughout. On the right, however, he had no palpable distal pulses and only a venous signal in the foot. The right foot was cool, there was delayed capillary refill, there were no wounds, and motor function was intact. So we admitted him, put him on a heparin drip. We got some non-invasive flow studies. ABI was significant on the right for being 0.35 with a non-existent toe pressure, and left hemodynamics were normal. We vein mapped him. He had no vein on the right, and on the left, it looked like he had pretty good saphenous vein in the thigh and at the level of the knee, but it looked a little bit small below the knee. We proceeded to get some axial imaging, and on the CTA, we saw that he had an SFA occlusion, which was not too bad, but the problem was that on the runoff, we couldn't see a distal target. It didn't look like there was reconstitution of any tibial vessel in the leg or in the foot. So we pursued some more imaging, and actually on MRA, we were a little more optimistic. It looked like he had reconstitution of a diseased tibial peroneal trunk, but the PT went all the way to the foot. And this was also the case on the angiogram. So we thought about this. This was a relatively young patient, 50 years old, chronic problem. This was rest pain. It wasn't like a wound that we needed to heal. And so we wanted to approach this with a revascularization strategy that we thought would be most durable. And so we thought we should try and do a bypass in this patient. So we took him to the OR and we did a right femoral to posterior tibial artery bypass. We explored the left saphenous vein, and it was actually very good in the thigh and the knee, but then in the lower leg it was indeed quite small, and there was no way we were going to make it bigger. It was too small. We looked at the right saphenous vein because sometimes the vein mapping is wrong, but it was actually too small. So we ended up doing a composite bypass graft using 6mm ring PTFE proximally and contralateral reverse saphenous vein distally down to the distal anastomosis. And this was our completion angiogram. This is the proximal PTFE graft. Here you can see the transition between the PTFE bypass and the saphenous vein. So we did an end-to-end anastomosis there. This is the vein throughout the leg, across the knee, and down to the distal anastomosis, which I'll point out actually was patent despite this horrendous picture, except that he had severe vasospasm. And we saw this immediately when we exposed the posterior tibial artery. It shrank from a normal-looking vessel to a thread. This angiogram caused a fair amount of angst. We gave him some nitro, injected some papaverine, and waited for a long time. And in the end, he had a palpable pulse. So we took him to the ICU, and his right foot pain improved. He had multiphasic signals in his PT. He had a DP signal, which he definitely didn't have before. But the ABI was not great. It was only 0.6. At this point, however, we thought that he had no other surgical options, so we sent him home on warfarin for his high-risk bypass graft. He came back a month later for regular post-op follow-up. His symptoms were better. He was walking. He had actually minimal complaints of numbness in his foot, and he had signals in his foot. However, his ABI was back to 0.3, and when we duplexed the graft, it was occluded. So this was one of those cases where we thought, well, maybe we should have considered recanalizing the SFA and popliteal rather than trying to do a bypass right off the bat. And just a couple of things, our decision for endovascular versus surgery is often based upon the BASIL trial, which granted is several years old now, but did tell us that overall there was no difference in overall survival or amputation-free survival. But in patients surviving over 2 years, it looked like surgery would be associated with a little bit better, but statistically significantly better overall survival. But I think what we often take from the BASIL trial is actually the post hoc analysis or the by treatment received analysis, which was not the original intention to treat analysis, but it's important to look at these also. And this tells us that vein works better than prosthetic, which was nothing new. But in BASIL, as is in the design for best CLI, about 25% of patients received a prosthetic graft. But the thing that we often take away from BASIL is that in the patients who had a bypass after failed endovascular therapy, they seem to have worse outcomes overall. So granted, BASIL trial is several years old, and the endovascular interventions for BASIL are much different from what we do now. If you look back at the 450 patients randomized in BASIL, only 9 cases had stents, whereas today, it's a huge array of possibilities for endovascular therapy. The other thing that wasn't covered in the BASIL trial is the composite bypass graft, which is a combination of PTFE and saphenous vein for those patients who don't have the optimal thing, which is a single segment saphenous vein. There was one study from Northwestern, small study, but showed pretty acceptable patency, sort of right in between what you would expect for single segment saphenous vein and PTFE bypass, with acceptable limb salvage at 2 years. Here are some possible configurations for how it might look besides the end-to-end bypass. And so there are different ways to do it, but it's basically a combination of prosthetic and vein bypass. So, this was our case. Basically an occluded SFA popliteal with pretty good distal target in a patient who's relatively young, so you're looking at a long-term problem with rest pain. We thought we would try to do a bypass, but in the end, possibly we should have maybe considered endovascular recanalization first.